Viren Shetty is the Executive Vice Chairman of Narayana Health, one of India's largest hospital and healthcare companies. Viren is a graduate of the Graduate School of Business at Stanford and has, over the last 12 years, been instrumental in growing Narayana into a company worth over $3 billion. We discussed a variety of topics in this podcast, including Narayana's foray into the health insurance space, how the company can free up capital in what is a capital intensive business, and the changing perceptions of the hospital business in recent years. Hi Viren, welcome to the Sensei Kujaku Show. Thank you so much for coming on.
Oh, thank you. Great to be here.
I want to actually start by giving the audience some context in terms of what Narayana Health actually does. So could you just give me a brief overview of the company and the different businesses that you're in?
Sure. The simple narrative is that we're a healthcare organization. We run 24 healthcare centers across the country, ranging across all formats. We run very large quaternary care hospitals that do very advanced surgery, cancer treatment. We run clinics, we run pharmacies, and in a couple of months' time, we'll be running insurance as well. We are mostly located around India, in South and East India mostly, but we have a presence in Central and North India as well. And we have one hospital in the Cayman Islands, that is a small, tiny island in the Caribbean, and we're building another there. The way in which we've positioned our brand is one of providing affordable healthcare, because healthcare, as you know, affects everyone, whether you're rich or poor. And private healthcare is generally perceived to be quite unaffordable. And for that, we believe that principles of sound business and efficiencies can be brought into the healthcare industry as well and be able to provide something that more people can afford. And that's been our life's goal, to make healthcare accessible to nearly everyone who wants it.
Fantastic. And I'm going to go into each of, many of the things that you said individually. But I want to start actually with a slightly more philosophical question. So your company, you've stated many times that broadly speaking, your target audience in a sense is not the most affluent sections of society. It's more the middle class and sort of people who don't necessarily have access to the best healthcare otherwise. So can you talk to me philosophically why it is that section of society that you've targeted?
See, healthcare is for everyone. It doesn't matter whether you're rich or poor. It doesn't matter. What matters is the sort of disease you have. And what matters to us most is that we are an Indian organization. And if we have to serve Indians, the services you offer need to reflect the demographic reality of the environment you're in. If, for example, we started our institution in Luxembourg or Geneva, some fancy place, then we'd be targeting the average Genevan who would be rather wealthy. And so it would be targeted in a very different way. But in India, you cannot but look around and see a sea of people, most of them who look upon these absolute five-star marble-clad palaces with a sense of maybe longing, maybe envy, or maybe a sense of shame that, there's all this infrastructure that's coming up and it's not for me. Now, it's not that they're not customers. One of the most important realizations that Dr. Shetty had very early on in his career is that everyone can pay. They may not pay the same amount. They may not be able to pay at the same time that everyone else can, but everyone can pay. And there is a service that is available. And it is the onus on the industry, on the enterprise that's trying to make money in India, to figure out what market you're after. And it's not to say that only one model or the other will succeed or one is superior to the other. It is that we're trying to build the largest healthcare business this country has ever seen. We're trying to build the largest and most impactful healthcare organization this world has ever seen. And hospital services is one in which you end up being a sort of middleman. You're not in control of a lot of the input costs. The medicines are not made by us. The equipment is not made by us. A lot of the buildings and so on, it's made, but the costs are not under our control. And so what is the value that we add? You can either take it for granted, everything costs this much, there's nothing we can do. So it's going to, we just add 20, 30% on top of everything we're spending and charge it to the customer. Or you can say, I'm a value-adding organization. And what does that mean? I'll bring in efficiencies. I will figure out that, fine, I can't change the cost of a brick, but I can change how the brick is used. I can't change the cost of an MRI, but I can increase the number of people that use MRI. I can't change how much this medicine costs, but I can make sure it's delivered in a sterile environment where someone doesn't have an infection, so I can use less medicine. That is value added. That is the purpose of an organization. If not, then there's really no sense in building such a large system. So that's what our goal always is, to keep adding value, to keep adding to what's called the consumer surplus, that when customers come to us, they are being provided first world levels of healthcare, but at a price that is a lot closer to what they can afford. And if something is too expensive, then we try and see what is it that we can do to bring the cost down. So the philosophy is more of volume, scale, and being more relevant to the larger demographic in this country.
I want to actually talk about the hospital business again from a public markets perspective. So I remember about 7-8 years back, sort of pre-COVID basically, a prominent narrative when it came to hospitals, again, this is not specifically your company, just hospitals generally, was that they're not necessarily great businesses, and sort of the primary beneficiaries from an economic sense are the doctors, and the shareholders of the hospital don't necessarily benefit. And now I look post-COVID, there seems to be this dramatic change in the narrative. And again, I don't blame you or any of the other hospital owners. It's the public markets investors who have to question why these things change and why their thought process changes so dramatically. But I just want to get your sense of, do you think fundamentally the business has seen a sea change at a fundamental level pre and post COVID that maybe to some extent justifies that narrative change?
I guess without getting into the overall philosophy of public markets and whether value should accrue to the shareholders, stakeholders, customers, employees, that's well beyond the scope of what we're here to discuss. The sentiment change relating to how the overall sector was perceived would say that I don't think the questions were wrong, that any person who's looking at the public markets, any person who's looking to invest in the sector, whether in the private equities or in public equities or the banks or the government, the questions have always been the same, which is, this is meant to be a public good. Nearly every country that's middle to developed, it's mostly provided by the government. In India, still a large proportion of healthcare is provided by the government. Why should a private healthcare system exist? And if it does, who should pay for it? How should it be paid for? Because again, as a public good and as a fundamental right to health, how then would you explain the fact that this is provided through a very large private sector that has to meet competing needs? You need to meet the needs of your employees, of the banks who lend money to us, of the vendors and all the suppliers who provide us with the medicines and the material, as well as shareholders on top. So you're adding stakeholders piled on top of one another. Now, those questions have never gone away. I guess what would happen during COVID is that the overwhelming sentiment around recognizing there's a huge need, there's a massive gap in service delivery, and the public sector is not able to pitch in to be able to provide those sort of healthcare services. And so you see a private sector that's jumping up and raising their hand and doing that. And so you get a lot of support in that direction. But it will never take away, if you want to call it the negative sentiment or the right questions being asked. Even though I run a large publicly listed healthcare system, I don't believe that it is the primary role of the private healthcare sector to provide healthcare services in any country. I think that role should belong to the public sector. It should belong to society, and that's how it should be. But things being as they are, and globally, we're seeing a retreat of the government from providing public healthcare services because the needs are so complex. It's not as simple as other public goods like roads, electricity, or so on, where the fundamental technology hasn't really changed in 50, 60 years. It's highly specialized. It's very, very difficult to provide the same levels of care. So I would put it another way. I would say that there is a level of discipline that being in the public eye brings you in a way that accountability probably does not exist if you are, in the end, assured of a minimum amount of spend from the public purse every single year. And that discipline translates into cost efficiencies, measuring your throughput, measuring the output. And so anyone who questions and anyone who says, yes, this is a good sector investment is right to question. Anyone who's enthusiastic about it is right to be enthusiastic about it. From our side, for us, this is just one more angry and demanding cohort of people that we have to listen to. We spent the first 16 years of our company being privately, well, 8 years being privately held, 8 years after that being held by private equity investors. And it's been, actually 8 years after that as a public company. Dealing with customers, dealing with vendors, dealing with patients who all will question, why is this like this? What's this item on my bill? Why aren't you paying me enough? Why aren't you paying me on time? Now we have one more who's saying, think about your return on capital. Think about your efficiencies. Think about, how much money you're returning to shareholders. All valid questions, because if you're not able to meet the needs of all your stakeholders, then you simply don't build a business that scales. You optimize too much. You can imagine a multi-sided polygon. And if too much weightage ends up in just one of the quadrants, you end up with a very misshapen object. So we have to meet all needs. I'm not here to debate whether it's right or wrong. I think a lot of the learnings we've had as a public company on the cost efficiencies have been very valuable to us and have taught us the areas in which it's worth investing for providing service and the areas in which you end up with these rather large vanity projects. Now, the sentiment, I can't say if it's rightly placed or misplaced. I don't see. The thing is, the charts on the graph, right? Share price over the past 6-year, 8-year performance, and you call it market value. And then something happens, some announcement from a government, and then the chart goes down. And then something good happens, and then the chart goes up. Or something completely extraneous happens, completely outside of your imagining, and the line goes down again. Is that really value, or is that sentiment? In which case, then you just have a real-time ticker on how people feel about you, not necessarily on how much value and good you're providing to society. And the two can get completely disconnected. So it's better not to dwell too much on all of that. There are questions within all the noise that are valid, which is focusing on return on capital, focusing on cost discipline, expanding where cautious, pricing yourself well, positioning yourself for growth, not getting too much into debt, that any enterprise should pay very close attention to. Anything beyond that, whether your multiple should be 18 times, 20 times, 30 times, 40 times, it's hard to tell whether it's noise or whether it's of real value.
Has being in the public markets made you a bit of a stoic?
I think being in any enterprise has made me more of a stoic. Just these sorts of things come with age.
Fair enough. So Viren, I want to now discuss the business a little more closely, and I sort of think about it, if I'm trying to think about it from a pure sort of, in a sense, unit economics standpoint. It's not really that, but for lack of a better term, if I think of the average person in an economy, and if you take a lifetime spend on healthcare, I'm saying at an average level, and I see the things that Narayana is doing more recently, for example, the health insurance business, NHIC, I get the sense that your goal is to capture an increasingly large share of that overall lifetime spend pie. Do you think that's a fair assessment?
Yes. But the realization we came out of it was not through startup economics, because these people do get a little focused on cost of acquiring a customer and the lifetime value. I think we organically came to that realization. What a person's lifetime healthcare spend looks like is very chunky. So when you're newborn, there's a little bit of spend over there. Then it's basically nothing until you're in your 30s, then maybe a little bit in checkup. Then in 40s or 50s, you may have a heart attack. There's one spend over there. 60s, maybe a knee replacement or some sort of joint replacement, a little spike over there. And you get to your 80s and then your ICU, and it's a massive spend over there, and then you're dead. Now, if you're building infrastructure to deal with this highly chunky sort of spend, you end up with these massive palaces, these absolute gigantic monoliths that we built, which is built around acute care emergency care, cancer care, heart care, things that this is what you're about to die. So that's invariably what you're going to end up paying for. And you have an entire healthcare ecosystem distorted around these once in a lifetime events. Now, what does that do? You train your customer to equate healthcare only with that acute levels of care, with only, I don't need to think about my health. I'll only worry about it when I'm having my heart attack. I'll worry about it when I find some sort of cancer nodule. I'll worry about it when I'm about to give birth. Prior to that, not my problem. Now that does several levels of disservice. One is, the customer is quite wrong. A lot of these are very easily preventable conditions. Can't completely protect yourself against cancer, but there are ways in which early detection allows you to get at it earlier. So to change the narrative around that, to say, okay, healthcare is not just cancer surgery, it is overall wellness. It's not just heart surgery, it's heart health. So that involves a very different way of building systems. Now, there is the public health angle and why it makes sense for us, but there's also a simple infrastructure utilization angle for why when we build these massive palaces, they end up not being utilized for large chunks of the day. We build huge spaces, we build lots of MRIs, we build lots of emergency rooms. And again, just like over a person's lifetime, the utilization of healthcare is chunky. In a hospital as well, the utilization of our infrastructure is very chunky. And it need not be. So if I'm trying to go at it from purely a utilization problem, I would say my outpatient department should be a lot busier in the middle of the day, and that's not happening. It should be a lot busier in the evening, and that's not happening. My ER should be busy at all times of the day. And so the pivot away from acute care, surgeries, cancer care, and towards more preventative, towards more moving towards clinics, coming closer to people's homes, start offering insurance, is all part of this gradual organic evolution of what healthcare must move towards, which is not just end of life, not just life-threatening stuff, but things that make it part of the daily conversation. It will improve healthcare outcomes. It will lower your overall cost of healthcare spend, but the utilization of our infrastructure has to go up, and everyone's level of healthcare utilization has to go up. My favorite things to do when I go to any gathering, they'll invariably talk about some uncle who got a heart attack, or some neighbor or some friend of theirs or someone they know got cancer. And they'll talk about it, and they just, out one ear, in one ear, out the other. And I ask, have you got a checkup done? And I'm of a cohort where, all the people I know are entering their 40s. And none of them think that this will happen to them, even if it happens to their family members, and that they share a lot of the genetics, and it's quite likely that something bad is going to happen to them. Everyone assumes it's someone else's problem. So it's not entered the public conversation yet. Prevention, getting checkups, getting a CT scan, getting your cancer screening, none of that gets in. So we do have to change the narrative what healthcare is about. We do have to change how you perceive Narayana. What you come to NH for should not be heart surgery, it should be healthcare. And we've had to invest an incredible amount of money towards building verticals we've never built before to move our customers in that direction.
I was going to ask this, but because of what you just said, anecdotally, I hear of a lot of cases of people in their 20s, 30s, even passing away because of sudden heart attacks and things like that. Are you seeing more of that in recent times than maybe 10 years back? Or is statistically at an aggregate level, is it no worse than it ever was?
Statistically, it's the percentage of the people in the hospital, the age distribution has not changed. It was always 40-year-olds, early 50-year-olds coming in for treatment. It continues to be. It has always been the case, and it has always been the case in society. It's just that awareness has increased, social media consumption has increased a lot, and the goalposts have shifted. 50-year-old dying in the 90s was much closer to the maximum life expectancy of the average Indian back then. I mean, 50 is considered old. Yeah, that person died. Big deal. Today, a 50-year-old or a 45-year-old gets heart attack. Oh my God, he's so young. That shouldn't have happened. It was always happening. Just enter in the public discourse as a thing that should not happen. And that is right. It should not happen. these are all very preventable. These are all very avoidable. These are all very easily treatable. It should not happen. Now, we're glad that it's entered the discourse and the awareness, but it hasn't. This is not a large-scale demographic. Now, maybe on the margin, because of increased awareness and because there are more hospitals available to you, while previously, 30 years ago, there were no hospitals. You just died at home and everyone just said, yeah, okay, I guess he died. Today, you end up in the ER, you end up in the hospital with more frequency. And so these are getting detected much earlier. So that's all it was. But just from what we're seeing in the hospital and the average age of the patients, it hasn't changed significantly from the time we started about 25 years ago.
I want to now talk about your health insurance business, which, I mean, technically hasn't even started in a sense. It's something that you're going to sort of, I think from what I gather, about 100 crores has been earmarked for now, and I guess more will go as things evolve. I want to understand the thought process behind this. And I know that given that it's not really sort of got going as yet, there's a limit to how much you can say. But so to the extent that you're willing to disclose, I'd love to get your thoughts on it. I was a bit confused as to why a hospital chain decided to get into that for a few reasons. So one, before I really ask my questions, I just want to better understand the average customer you foresee for Narayana's health insurance business. Is it simply people who live within a certain radius of your clinics or hospitals who you think would anyway naturally tend to be your customers, and so therefore to capture those within a certain radius you want to offer them health insurance? Or do you see this as anybody, even in a city where there is no Narayana presence, would be willing to buy something like this?
Let's start with the first question. Why health insurance? Why should we do it? What right do we have to run a business that we have never run before? So imagine a group of 10 of your colleagues, friends, acquaintances, and let's assume all 10 of them have health insurance. How many of those 10 do you think will be happy with if they've experienced the services? How many of them do you think are satisfied with the levels of claims or the way it was done? Or you think 10 out of 10 are happy? 8 out of 10? So do you think even 1 out of 10 would say, yeah, this was a thrilling, joyous experience for me? And compare that to any other service experience that you pay for on a recurring basis. Your Netflix, okay, I mean, you're happy with Netflix, and so you keep subscribing for it. Your vacations that you go for on an annual basis, you're happy with the overall experience. There may be little issues here or there, but you don't mind it. You overall enjoy it. School, again, you end up enjoying experience. The electricity that you pay for, I mean, it comes and sometimes it doesn't come, but you're happy with the overall experience. But health insurance, in any room that I go to, nobody is happy with the way it is structured. Now, there are much larger factors around the way the industry is structured, the way in which the distribution of these products ends up, over-promising, under-delivering, the way in which the regulatory structure has created certain ways in which it's hard to deliver. But you go back to first principles. What are you really doing when you're providing health insurance? Are you selling policies or are you selling health? If you're selling policies, then what they're doing is 100% correct. It should be about chasing scale. It should be about selling as many as you can. And what you said, should we go to all the other places throughout the country, offer Narayana branded insurance, sell as many policies as we can? You're right. But we're not in the selling policy business. Since the time we started, we're in the selling health business. We sell you health, we sell you happiness, we sell you peace of mind. Now, that means the thing that we offer is very, very different. So again, this is all what we disclosed before. What we plan to end up offering is something much narrower. Not 20,000 hospitals, but a much smaller subset of hospitals that we work with. Not throughout the country. We will not chase scale. We're starting in Mysore and Bangalore, and that's where we plan to be for a long, long time till we get this right. Wouldn't sell policies to anyone. We were not confident that we can take care of them. If they're in a very remote part of Bangalore, completely cut off from access to any of our facilities, it's not right for us to take their money and deny them services. We wouldn't do that. Health first means that there will be a tremendous amount of screening. upfront. This is tied up with a proper doctor evaluated screening protocol, not just done by a technician who goes through a list and just ticks off a bunch of things. No, this is done by a physician. And should you enter a risk bucket, you are seen by a cardiologist. If you are pre-diabetic, you're seen by a diabetologist or endocrinologist. If we have suspicion that you may have other, GI or kidney or any of the other issues, you will get seen by a specialist before you get the insurance. So you get the full checkup and you get to know exactly where you stand. Are you in the healthy range? Are you in the, better watch out range? Or are you in the, oh God, there's something seriously wrong with your range? You start with that. And so you think of it more as a bundled healthcare services product that you're paying for the healthcare delivered to you over your lifetime. But it's called insurance because that is the wrapper that, as per the current structures, that's the way in which we're allowed to sell it. But what it really is the total health. If you're sick, all your medicines. If you have some chronic conditions, whatever medicine required for that. If there's a surgery, the surgery is included. If you're expecting, then the gynecologist, obstetrician, all the things that you require. If you are just generally of healthy disposition, still having annual checkups with the physician or a nutritionist or a psychiatrist or a diet planner would not hurt. And that is the set of services we are planning to offer. Small, limited, contained within a narrow network of providers. Priced, we haven't figured out how we price this yet. Whether we make money on this, again, completely unclear. But if we go with satisfaction first and services first, we think we will provide something that the market has not yet seen and that customers will really value. And we may end up losing a lot of money doing this, but we think that enough people value this and they keep buying this again and again. Eventually, you can break even on that.
Are you at all concerned about it being viewed, even though you may not do anything wrong, but from a regulatory standpoint, it being considered bundling in some form? Or how do you ensure that, even though it may not be true, the perception that that is the case is not, it's not the prevailing perception?
So the model is not new. The thing that we're offering, we didn't come up with this independently. This is literally a copy paste of integrated healthcare models that exist in several parts of the world. So in Brazil, there are these cooperative healthcare systems where you join a cooperative, it's a healthcare cooperative, and it gives you access to the pharmacy, the clinics, and the hospital of that cooperative. And you pay member dues and you get access to the network. In the US, it's called either HMO or ACO or integrated care or value-based care, where a bundled set of providers come together and then they sell a plan and it gives you access to those providers as part of the plan. So, in terms of how it would be perceived, we didn't reinvent the wheel in this at all. We just took a model that's been around since the 1970s and we said, this makes a lot more sense for a country like India, where there's not a lot of healthcare awareness, not a lot of healthcare penetration, and this can reduce cost, this can improve healthcare outcomes. So let's try it. The regulator has been tremendously supportive of our efforts to build something that's quite different from what exists out there. They are allowing us the space to try and experiment with this and to see if in the end, they're more concerned that people get insurance and people get value and there are less complaints. If we're able to provide that, we provide value. If there are no complaints and we provide good healthcare services, there's no reason for any issue on the regulatory side for this.
And do you think that the model that you are contemplating employing, it is in some ways a relatively lower cost model than, say, the prevailing model, and because you may not need the branch network, the agent network that a lot of other standalone health insurers need. So do you think that, for example, if you take the way Geico has grown in the US, I know it's for auto insurance, but it's that same model, right? That you, in a sense, cut out the middleman, so therefore everyone, the other two, the provider and the insured, benefit. Is that, broadly speaking, your thought process?
So the Geico motor insurance example is one in which every single variable stayed the same other than the distribution cost. And so they were able to cut out the distributor and be able to, offer lower commissions, no commissions actually, and offer a lower price product to customer. It's not relevant for us because in this, every single thing is different. we're offering primary care, we're offering medicines, we're offering a lot more proactive interventions that are bundled with the service. You don't have to pay extra for it. We're offering, eventually, in some of our plans, it will offer a lot more healthcare without exclusions if you're in the network. So, yes, being smaller, not going with national scale, not going the distributor route, this cost bucket goes down. But the healthcare utilization, the services, all of that goes up. So we can hope that it nets out, in which case you can offer a similarly priced product and you would offer much higher. Like, that is the holy grail for us. If we can achieve that, if we prove we can achieve that and still break even on the product, great. We don't know for sure that that is the case. We think either, if, for example, you're not, without distribution, you can't get scale, then, you end up too much on the expense side and not enough saved on the distribution side. Or if it turns out that you actually do get scale, but the utilization is through the roof because of adverse selection, then you have a problem on your cost side too. So those are things we have to see. Fortunately for us, we are, learning, we are experimenting enough, and the customers that we've spoken to through all the surveys we've done trust us enough that they say, look, provide something and we'd be happy to test this out to make it happen. And if not, we will learn, we will pivot, we will, adjust the pricing accordingly. So we're not clear yet on how this thing will be priced, but we're very clear that the number one goal for the first couple of years is not to make a lot of money off this and not to chase national scale. It is to provide something that customers absolutely love. Because if not, this market doesn't need another insurance plan that people are dissatisfied with. There's enough of those.
Right. And so, what you were describing in America and some other countries, it's sort of like, so companies like Kaiser Permanente, and I think you yourself have spoken about that model in the past. Can you explain to me, in your view, why you think that's a suitable model, and what do you admire about that model, and what do you think are the best practices from a business perspective and otherwise that you want to implement at Narayana?
All of us like it for different reasons. Dr. Shetty likes it a lot because it provides this really great value for the customer. So Kaiser plans are priced a lot lower than most of the other health plans, and they offer a great amount of value and great amount of clinical satisfaction, and they do offer really good results. So he sees that in it, and that's something he wants to replicate. And of course, he likes the fact that it is so different and perceived so differently from a plan that you get from Aetna, Cigna, United, whomever. I like it because, my background is in engineering and numbers and looking at throughput and utilization. For me, an assured set of demand that is pre-planned and predictable is the greatest gift that anyone in the capital deployment business could ask for. Today, we make massive thousands of crores worth of investments in heavy physical infrastructure. Now, our business is not like the public infrastructure business where you spend a couple of thousand crores, build an airport, you are given a monopoly. No one else can build an airport. You spend another 1,000 crores, build a road, no one's allowed to build a road next to you. So you're given that assured monopoly. Some of these contracts, which have heavy upfront investments, even come with guaranteed ROEs. Right? The return on equity, 14-16% is guaranteed, and you're allowed to raise or lower your toll or your user subscription charges based on that. Our business doesn't have that. So we have all the uncertainty of uncertain consumer demand, planning for a future we don't know will exist or not, no guarantees at all given by the government on that we get a monopoly or so on, because India doesn't have zoning laws. We don't have this thing called certificate of need. Most other parts of the world with zoning, you build a police station, you don't build another police station next to it. The police station goes in another place, and similar to a hospital. You build a hospital, another hospital doesn't come right next door to you, it goes somewhere else. So we get a very irregular distribution of healthcare infrastructure of the country, where too much gets concentrated in fewer big cities, and even in the city, it's concentrated in just a few wealthy suburbs, which happen to be where the doctors live, and the rest of the city will have nothing, and the rest of the state will have basically nothing. So for someone looking at utilization throughput and getting an assured return on the capex that they deploy, the greatest gift for me is knowing that there are 1,000, 10,000, 1 lakh, 10 lakh people who are guaranteed to come here per month, per year, however the number works out. And based on the data that we will have, we will know exactly what sort of disease pattern they will exhibit, what sort of utilization they'll come. We'll be able to pre-schedule a lot of that. And so we can staff according to need, we can build infrastructure according to the need, and we can commission capacity exactly according to pre-planned need. Because right now, it's essentially a crapshoot. We're all just guessing as to what the eventual demand is going to be. And so we front load a lot of investment, and that's why the overall return on capital in this industry has been horrible and continues to be horrible, even less than the cost of capital.
It's interesting you're talking about, the use of data, and obviously any large hospital naturally collects a lot of data. Now, whether they make something of that is a whole separate story. But I want to talk about that in the context of the technology investments that Narayana has made in all aspects of the business, right? So there's technology implemented internally for doctors, nurses, managing patients, all of that, and even there's a consumer-facing technology front as well. Can you talk to me about how, after implementing those over a few years, what do you see as the primary uses of that data and anything else that comes out of it from a sort of dollars and cents perspective in terms of either saving money or providing better service or anything else that you think is the case?
For the past now 8 years, we've been spending ungodly amounts of money on building our own technology platform to solve what is essentially a coordination problem. So you have a two-sided, okay, let's talk in tech terms, a two-sided network. You have a set of customers with a set of demands. I need medicine at this time. I'm a doctor. I need an instrument at this time. I am a patient. I need to be admitted at this time. And then you have a finite set of supply. I have a nurse who's available only then. I have a medicine that only comes in the store at a certain point in time. I have a doctor who's only going to show up at a certain amount of time. And I have very limited infrastructure in which to solve all of that. Now, traditional business would solve it the good old-fashioned way. You just throw a bunch of people at the problem, and then the people become the nodes between the two. So a medicine problem is solved by putting pharmacists and delivery boys, and maybe the software is only used for generating the prescriptions, but it's essentially a manual process that's slightly faster because instead of writing, you're typing. Or if you have a doctor and you're trying to figure out how many patients they can see a day, you solve that through coordinators and administrators and secretaries and phone calls. And again, a completely manual process. The role and you said the dollars and cents part of our investment technology is fixing the inefficiencies inherent in a completely offline system of coordinating two sides of the equation with something that's simpler, completely networked, end-to-end, automated, and tomorrow, we're not there yet, predictive. Now, we're still in the early stages of that. We've built so much, and we're still barely in the early stages of automation. Automation essentially means rather than having a runner deliver a digital prescription from one to the other, it gets sent automatically between the doctor's office and the pharmacy. What used to happen before? The doctor will print out a prescription, comes out, the patient physically delivers it to the pharmacy and picks it up over there. So at least we're in, the 1.5 version of the software where at least from the doctor's office goes directly to the pharmacy, the patient gets. Tomorrow, we want the pharmacy to be able to predict what to stock based on the demand that we generate on a Monday. At 4 o'clock on a Monday, we're more likely to see heavy inflow in certain departments than others, and we stock based on that. So that is the first role that we have in technology. Everything outside of that is just a simple, either a variation on this technology or a toy. If you talk about AI for prescription generation, sure, maybe, or you want to use, the fancier technologies that are able to replace the digital doctor. At this point, it is a toy. But you want this to impact the business. You want to run better, cleaner, faster, more efficient operations. You are essentially using this to solve the most boring business in the world, which is moving information from one node to another without it getting stopped anywhere by a person who has to decide whether they show up or not.
You were talking about procuring medicines. Can you quickly just explain the procurement model at Narayana? So whether it's medicines or consumables of any form, Has that evolved in in any meaningful way in recent times? And what is the basic process? Is it just a sort of tender process, or how does that work?
It is a tender process because we run a central purchasing system. Now, if you see your role as a hospital is just an agglomeration of doctors on one side, and the doctors draw in the patients, then you're just in the demand fulfillment business. So the doctor says medicine A, you have to stock medicine A. Another doctor says medicine B, you have to stock medicine B. Another doctor says medicine C, you stock medicine C, and the patient chooses among that. And maybe they'll complain about A or B being too high and want C, but that is a way in which you are playing no role. You're just in the pure demand fulfillment role. You're not adding value. You're not reducing cost. You're not changing the game. Now, if you say, I'm in the efficiency business, I'm in the business of adding value, I'm in the business of providing more value for my customers. So then A, B, and C for the same disease, basically the same molecule, but A, B, and C are three different companies. We would consolidate that and put that into just A or C, whichever, whoever's able to offer the most value for the customers. Now, we did that years ago. And so that's why we run a very large central procurement system that works very closely with the doctor, that comes up with a narrow formulary. Formulary is the number of molecules that you hold, and optimize for the things that provide the best value. So if we have finalized with a company, but then going through the data, we find out that actually it's not clinically effective. Because a big problem in India is that because of price control, a lot of medicines have very little active ingredient in them. And so you end up having to use more medication to achieve the same effect than you would for the same company selling at a higher price to a Western audience. Now, there are companies that will compromise on those. There are companies that will never compromise. But it's hard to know until you actually use the medicine. And so with our central system, we'll be able to very quickly figure that out and figure out that here's the culprit. This is the company that's selling us chalk instead of an active molecule. Get rid of that company and go again. You'd never be able to do that if you had 12 different antibiotics. That's next to impossible. So you're not improving value, you're not making patients healthier. You'll never be able to find out who's messing up and who's not. So our procurement is centrally managed. We have a very large team that's able to quickly identify companies. The actual purchasing is, again, it's a normal tender process, but it's not a tender process in the sense that we just go for the L1 as the lowest price. You go for the one who's providing the best value and who's actually providing you medicines that make customers healthier.
Viren, a common issue for any hospital, and I think this is pretty much anywhere in the world, is that it's very difficult to generate free cash for the simple reason that whatever money the business makes inevitably just has to be plowed back, right? You have to keep building more rooms, upgrading the existing rooms. I mean, there's 101 costs, right? Have you ever considered some sort of alternate structure to maybe try and free up some cash? So, just as one example, is say a REIT structure or something of that nature. Has anything like that ever been considered, or is that not something you have any interest in?
So, I mean, there's two ways to think about this, right? Now, when you say free cash, is this the accounting treatment of free cash flow? Or is it free cash in that business, I want to be able to generate tons of money that I don't know how to invest? If it's the second, which is you're just generating more money than is able to be absorbed by the business, I don't think any business in India is there yet. Every rupee that gets generated by us is plowed back because India is a country of need and growth, and the population is growing, it is aging, and healthcare needs are going up. So regardless, the free cash will always be plowed back into adding more infrastructure because, as any bloodthirsty capitalist would tell you, you never leave an opportunity unexplored, right? And this is what the demands of the business require, perpetual, ever-present growth. But if we talk about the accounting treatment of free cash flow, yeah, I mean, a REIT structure would solve it temporarily. The REITs are not a charity. What you save in one, you give up in the other. Now, India is not a mature enough country where organized REITs would be the primary way in which you end up investing in capex, simply because the enforcement of contract law is quite sketchy. And so a lot of the international organized players who would otherwise come into this industry a little hesitant. We have spoken to quite a few of them. So they're a little worried. They say, what if you don't pay? what can I do? The problem with healthcare also is that the infrastructure is not very fungible. If you have an infrastructure today, it's owned by Apple. Tomorrow, Apple moves out. You can bring in a Microsoft, and they essentially use the same space. You don't need anything. But with the hospital, if hospital X comes in, hospital X says, "I'm not paying." You kick out hospital X. Hospital Y will say, "No, that's a wrong configuration. I don't want that." So there's not enough demand from the institutional investor side to do healthcare REITs. That's one. The other one, if you want to get into the math and finance behind it, REITs are essentially a bet on which way you think the interest rates are going to go. You lock yourself into a certain amount of yield at a certain point in time. There was a well-known listed player that was paying, I believe, 14 to 16% on their real estate assets, which made sense at a time when interest rates were about 10, 12%. But when interest rates fell down to 6 to 8%, it was really expensive for them. So they borrowed and paid it off. So the thing is, we are in the healthcare services game. We don't want to get into forecasting interest rates. And we're not a pure play real estate provider that's able to, generate those predictable cash flows. And so the REIT model, the institutional REIT model, didn't work for us from that perspective either, because we don't want to get into forecasting what interest rates look like. The last bit is the asset light model, one in which you don't go to institutional players, you go to individuals. You go to professional, semi-professional, non-profit. You go to people that aren't terribly financially sophisticated and who won't mind taking the risk of subletting their infrastructure. The problem with that is you do get the advantage early on in that you get the infrastructure essentially for free, and you just need to pay them a variable amount, mid to high single-digit percentages of your revenue. The problem with that, for us at least, has been twofold. One is something linked to your top line scales exactly linearly with your performance. So the burden of payout, while in the first couple of years, you're at an advantage because it's less than what the interest payout would be. The thing about, using debt to pay for CapEx is after 8 years, it's over. But when you're paying 7, 8% perpetually for the next 30 years, after 9 years, you're going to start to kick yourself and realize, I shouldn't have signed up for this thing. I'm paying this person forever. And the other thing that's happened to us in the past also is that the healthcare, the hospital is not a single contained, a 200-bed hospital is not a 200-bed hospital forever. It is perpetual. And it is something that you need to keep investing, keep growing, keep refurbishing, keep getting in more and more, in a way that a hotel or an office complex or an apartment need never be. Because the way people live hasn't changed. The way people stay in a room has not changed in 100 years. But the way a hospital works does change. It changes every 10 years. And so there's extensive internal requirements of breakage, and not just in terms of walls and floor and so on. That's interior work. That's easy. Talk about large-scale reconfiguration, changing the power supply, changing the entire layout of an area, adding more beds, adding more floors, adding more wings. Then the problem with us has always become, whose responsibility is that? If you go back to the unprofessional investor in that instance, they will say, okay, fine, but now I know you're desperate, and guess what? My price has just gone up because I know you're stuck. Or they may say, look, we're not going to invest anymore. And so you have a situation in which you're not able to scale your growth, your revenue doesn't grow as much, your cost structure keeps getting higher and higher, and eventually your margin will get squeezed. So for a short time frame, I can see the appeal of asset-light REIT models, and we were the pioneers of that. We did that before everyone else. It's just that when you're early to a thing, you eventually also realize quicker on that these things may work for some groups and may not work for others.
I want to end with two questions that are not necessarily really business linked. One is quite lovely and one is a bit morbid. So I'm going to start with the latter so we end on a good note. About at the end of 2023, someone we knew passed away, and we were talking to the family, and something, I don't know how, but it came up, was that person. So this is like late November, early December 2023, right? Yours basically done. The person who passed away had decided to donate his organs. The amazing thing was, he was in that year the third person to do that at that hospital. I'm saying among the people who passed away at that hospital. And this is a prominent Bombay hospital, right? Yeah. So I want to understand from you, Do you have any thoughts on how we can improve that? We can, I don't want to call it incentivize, but how we can promote the idea that people should be donating organs, or I mean, it's a very general question, but if you have any thoughts on that.
No, the easiest way is to do what countries like, I think the Sweden or Norway are one of those, where they said everyone's an automatic donor, you have to opt out. In India, we have an opt-in system. The problem with an opt-in system is that just not even from a sense of malevolence, or it's just apathy. Most people wouldn't bother to check and say, I will be an organ donor. It never occurs to you. Most people don't want to think about morbid things, and they have every right not to. So the easiest thing would be for a country with so much need, and for the fact that we're the diabetic capital of the world, and there's a tremendous need for kidneys across the board, and we also the cardiac disease capital of the world, and a lot of people with heart failure that need heart. I think just on a policy level, we have to push for an automatic opt-in. And at the time of when you get your Aadhaar card or driver's license or passport, you have the option to opt out and say, I'd rather not. So I think that would just make that decision making automatic. So society as a whole will reorient itself towards saying that, what, we are a giving society, which we are. Indians are among the most giving people on earth. If you made everything opt-in automatically, I don't believe that people will willingly say, no, this is not the case. It's just that people don't want to think about it. So that's the most important one. We have to do what a lot of behavioral psychologists say, go for an opt-in mindset. But other than that, I would say, look, the awareness is increasing. And here's the thing, right? You opt in for organ donating. It also means that should you ever need it, at some point, that you're counting on the like-mindedness of someone else who has also opted in to that system. So even if you want to be purely selfish and you want to hoard all your organs for yourself, just recognize that everyone who thinks like you will also benefit from your opting into, donate organs. So that's what I would say.
Sort of going through your own career and sort of how one thing led to another that eventually brought you where you are today. What has been your lessons you've learned on just embracing that chance and opportunity in life, and just enjoying the serendipity that life offers?
It's not serendipity if I have to give you the formula for how to achieve serendipity, right? And that's why I find self-help books such a joke. See, I think people in our industry, more than any others, are confronted by the specter of death almost as a daily statistic. It is an actual thing that comes in the review that we do. The business reviews also include the number of deaths that all of us face. And for us, it's just a number. But, walk across any hospital, you realize it's much more than a statistic. So you realize that, okay, fine, this is a cause, this is a mission. You can't take life too seriously, and you have to open yourself up to a lot of wonderful experiences. I don't think I can have anything prescriptive about that. It's just, and I think Indians are generally more philosophical than most. I think we do tend to open ourselves up to new planned experiences. And the universe does surprise you. I never thought I'd end up where I am today. I never thought our business would end up where we are. We are just continually surprised by how quick things change, how much things evolve. And we never imagined we would be running even more than one hospital, or running hospitals abroad, or running clinics and insurance. And how quickly we got an insurance license was just a surprise to us. One thing I would say is that it just takes time. That's the other thing. Like, if you're just constantly chasing that new high, you never build that time enough for life to surprise you. So patience is something I've had to learn, and that's something I would suggest to people that want, that kind of satisfaction out of the work that they do. These things, the results do take a lot of time.
Good things come to those who wait, right? Viren, thank you so much for taking the time. It was so lovely talking to you, and I hope you enjoyed this as much as I did. And it was fascinating learning about Narayana more, and thank you for answering all my questions.
Thank you very much. This was very enjoyable, and I hope people watch this and learn a little something.
I'm sure they will. Thank you so much.
Thanks.